Welcome back, everyone, to another deep dive. This time we're taking a close look at something I bet you use every single shift,
Oh, yeah.
even if you don't realize it.
Absolutely.
It's clinical reasoning. And with us, we have an expert who's going to help us break down
That's right.
how experienced nurses and other clinicians take a patient walking in the door and turn that into a solid plan for care.
Yeah, it's really fascinating when you break it down. Most of us don't really think about it
Right.
step by step when we're in the middle of a busy shift, but there really is a whole system at play.
That's so true.
Yeah.
Especially for all the nursing students and faculty listening, understanding those steps can be huge.
Oh, for sure.
And how you approach learning and teaching.
Absolutely.
And then, of course, patient care, too.
Yeah, for sure.
So I guess the question is, where do we even begin? It can feel like seasoned clinicians just kind of have this almost sixth sense
Right.
of what's going on with the patient,
Yeah.
like they're reading minds or something.
It's not magic, though it can definitely feel like that sometimes.
It really does.
One way to think about it is this thing called dual processing.
Okay.
It's basically our brains use two different systems to think.
Okay.
One that's super fast and intuitive, that's system one,
Mm-hmm.
and another one that's slower, much more analytical, and that's system two.
Okay, so that's like, like having a gut reaction versus really taking time to think things through.
Exactly, yeah.
Do you have any, nursing examples of that?
Yeah, for sure. Imagine a patient who suddenly starts having trouble breathing, right?
Okay.
Your system one might kick in and immediately be like, emergency!
Right.
And that instinct to act quickly, that's vital.
Oh, absolutely.
But then system two comes in to help you assess everything a lot more thoroughly. Like, what are their vitals looking like? What's their history? What specific interventions are we going to need right now?
Gotcha.
Yeah.
So it's almost like both systems are kind of working together, right? You need that quick thinking, but also that careful analysis.
Exactly. It's like having two expert nurses in your head,
That's a great way to put it.
each with their own strengths, And what's interesting is we actually use both of these systems all the time, not just in healthcare. Think about driving, right?
Okay.
Slamming on the brakes to avoid an accident, that's pure system one.
Oh, yeah.
But planning a route for a road trip,
Yeah.
that requires that more deliberate system two thinking.
That's a great comparison.
Yeah.
Okay, so we've got these two systems kind of happening, but how does all of that actually play into the steps of clinical reasoning?
Right.
Like, what does that framework look like?
It's actually pretty straightforward. The first step is just gathering information.
Okay.
Everything.
All the clues.
Everything from their story, what they're telling you, to their symptoms, the physical exam, even any initial test results you might have.
Okay, so it's really like you're gathering all the clues. You're like a detective.
Exactly, yeah.
But how do we do that in a way that's effective, especially when you're new
Yeah,
and it's all super overwhelming?
right. That's where having a really systematic approach is so important.
Okay.
Think of it like, organizing your tools before you start a project.
Okay.
You want everything in its place so you don't miss something important.
Right.
Having a consistent method for gathering information, make sure you're being thorough, and you don't miss any of those vital clues.
So what happens after we gather all those clues? Then what?
Then we go into analysis mode. That's where we sift through all that information, start looking for patterns, connections, anything that kind of stands out.
Okay.
And this is where critical thinking really comes in.
Right, so we're trying to put the pieces together like a puzzle almost.
Exactly.
Are there strategies that can help us do that, especially when we're still kind of building those clinical reasoning skills?
Yeah, definitely. One way is to think anatomically. So, for example, if someone's complaining of abdominal pain, you really want to zero in on those structures and systems in that area during your assessment.
Gotcha.
Another thing that's helpful is to think about their age, because certain conditions are more common in certain age groups.
That makes sense.
Yeah.
So you're not just thinking about the symptoms themselves, but you're also putting them into context. Where they are in the body,
Yeah.
their background, all that.
Exactly. Exactly. And then don't forget about the timeline of their symptoms, too. Like, when did they start? How have they changed? Are they constant or do they come and go? Those details can be super valuable clues.
Oh, absolutely. That timeline can be huge.
Yeah.
What about the cases where it seems like all the symptoms are all over the place? Like they're affecting different body systems.
Right. And that's when it gets interesting. because sometimes those seemingly unrelated symptoms
Right.
can point to a single underlying condition. And that's where having a good, solid foundation of knowledge about all those different disease processes comes in handy.
Oh, absolutely.
It helps you connect those dots and see those patterns.
It's like those medical dramas where they suddenly figure out the one rare disease that explains everything.
Exactly. Yeah.
So in real life, how do we avoid getting lost in all the possibilities?
So once you've gathered and analyzed all the info, the next step is to kind of synthesize everything into a concise summary.
Okay.
And that's what's called a problem representation. It's basically your initial hypothesis of what you think might be going on.
Oh, okay. So it's like we're formulating like a working theory of the case.
Exactly.
Based on all the clues we've gathered. But then how do we test that theory? Like, how do we figure out what's the most likely cause?
Well, that's where the real detective work begins.
Okay.
One approach is to come up with a list of all the possible conditions
Okay.
that could explain what's going on and then systematically eliminate the ones that don't fit the evidence.
Gotcha.
We also compare what we see in the patient to known patterns of disease. We call those illness scripts.
Illness scripts. I've heard that term, but can you give me an example? Like, what does that actually look like?
Yeah. Think of it like a mental model for a specific condition.
Okay.
So when you hear heart attack, you probably picture certain things.
Yes, chest pain.
Yeah, chest pain, shortness of breath, maybe pain radiating down the arm.
Yep.
That's your illness script for a heart attack.
So it's like a mental shortcut based on our knowledge and experience.
Exactly, yeah.
But can those scripts be dangerous if we, rely on them too much?
Oh, absolutely, because not every patient is going to present in that textbook way.
Right.
And that's where experience and critical thinking are so important. Over time, you start to recognize those variations on those scripts and learn to pick up on those little clues that might point to something less common.
Okay, so it's like having the mental models,
Right.
but also being flexible and open to new information. How do we balance that, especially as new nurses?
One key is to focus on the most specific and critical findings that support your hypothesis. So if someone comes in with a headache, it could be a million things.
Right.
But if they say it's the worst headache of their life,
Okay.
and then during your assessment you find neurological changes, those are very specific details
Yeah.
that point towards something more serious.
So you're looking for those red flags, those clues that really jump out at you.
Exactly. And here's another crucial point, especially for nurses, because we're often the first to see the patient. Always consider those life-threatening conditions in your initial thinking,
Yeah.
even if they seem unlikely at first.
Gotcha.
It's always better to be safe than sorry.
Yeah, that's a great point. Stay vigilant. Avoid that tunnel vision.
Exactly.
So let's say we've gathered all that information, analyzed it,
Right.
formed a hypothesis, ruled out any immediate threats. What's next in that clinical reasoning process?
That's where documentation becomes super important. And I mean, really clear and concise documentation.
Okay.
It's not just paperwork.
Interesting.
It's actually a key part of the reasoning process itself.
I've always thought about documentation as more of a record-keeping task.
Yeah.
So how does it actually play into clinical reasoning?
Well, when you document your thought process, it makes you be really clear and organized, which can actually help you catch any gaps in your reasoning or
Right.
areas where you might need more information. Plus, that documentation is what you use to communicate your findings and your plan to the rest of the healthcare team.
So it's almost like you're creating a roadmap for everyone so everyone's on the same page.
Exactly.
How do we make sure our documentation is as effective as possible, especially when we're new?
Well, one key is to focus on writing a really clear and concise summary statement, that problem representation we talked about earlier.
Okay.
It should capture the essence of what's going on with the patient,
Right.
their main complaint, relevant history, key findings, your initial thoughts.
So it's like writing a headline for their case almost.
Exactly, yeah.
Are there any specific techniques that can help make those statements more powerful?
Yeah, for sure. One tip is to use what are called semantic qualifiers.
Okay.
They're just descriptive words that add detail and nuance to your documentation.
Okay.
So instead of just saying headache, you might say acute headache, or chronic headache, or intermittent, or severe,
Right.
or even localized, things like that.
Yeah.
These specific details can actually help shape your differential diagnosis.
Wow, I never thought about the power of those little words.
Yeah.
They paint such a clearer picture.
They do, yeah.
Okay, so once you've got that summary statement, then you move on to the assessment and plan part.
Exactly.
This is where we take all of our thinking and actually turn it into actions.
Yeah.
What needs to be included there?
So the assessment should include a problem list
Okay.
and not just diagnoses.
Okay.
It should also include symptoms, any abnormalities, even social factors that might be affecting their health.
Okay. So we're not just treating the disease, we're treating the whole person.
Exactly. And then for each problem on that list, you want to explain the findings that support it and your differential diagnosis.
Gotcha.
And then in the plan, you outline the steps you're going to take to address each problem, whether that's ordering more tests,
Okay.
starting treatment, referring them to a specialist, or just monitoring the situation.
So it's really like a carefully crafted strategy to address every aspect of their care.
Exactly.
But even with the best systems in place,
Right.
mistakes can happen, right?
Well, of course. Even the most experienced clinicians are human. We all make mistakes.
Right.
One of the most common pitfalls is cognitive error.
Okay.
It's basically bias creeping into our reasoning
Right.
and potentially leading us down the wrong path.
Cognitive errors. Yeah, that's something we definitely want to avoid.
Yeah.
What are some examples of that? How can we recognize it in ourselves?
Yeah, one very common one is called anchoring bias.
Okay.
It's where we get fixated on one piece of information early on, and then we fail to adjust our thinking even when new information comes up.
Gotcha.
For example, if a patient mentions they have a family history of migraines,
Okay.
we might just assume their headache is also a migraine without really considering other possibilities.
So we're anchored to that first piece of information, and we have a hard time letting it go,
Exactly.
even if it might not be the whole story.
Exactly.
Are there any other biases we should watch out for?
Another really common one is called availability bias.
Okay.
It's where we tend to overestimate how likely something is to happen just because it easily comes to mind.
Okay.
So, for example, if you've seen a lot of cases of a particular condition recently, you might be more likely to diagnose it in the next patient who has similar symptoms,
Right.
even if it's actually statistically less likely.
So our recent experiences can really cloud our judgment,
Yeah.
even if they're not really representative of the bigger picture.
Yeah.
This is starting to make me feel like I need to constantly be questioning myself.
Well, and that's actually a good thing. Being aware of these biases is the first step toward minimizing their impact. There's actually a lot of strategies we can use to sharpen our clinical reasoning and avoid those pitfalls.
Okay.
And we'll definitely dive into all of that more in the next part of our deep dive.
This is already so helpful. I can't wait to hear more about those strategies.
Yeah, me too. And we'll also talk about how to communicate all this clinical reasoning through a compelling oral presentation.
Awesome. See you then.
Sounds good. Welcome back, everyone. Let's jump right back in and talk about how to sharpen our clinical reasoning skills and avoid those cognitive biases we were just discussing.
Okay, yes.
Yeah.
I'm definitely ready to get some tips to make sure those biases don't trip me up out there.
Well, one of the most powerful strategies is actually pretty simple slowdown.
Okay.
It's so easy to get caught up in the rush of a busy shift, but just taking a moment to pause, gather all the information, and really think through all the possibilities can make a huge difference.
So even when things seem straightforward on the surface, resist that urge to jump to conclusions.
That's it. Another helpful strategy is to actively look for other possible diagnoses, even when you feel pretty confident in your initial assessment.
Okay.
Challenge your own assumptions and look for evidence that might actually disprove your hypothesis.
So be your own devil's advocate.
Exactly. And don't forget about the power of collaboration. Talk to your colleagues, get input from those more seasoned nurses. That can really help you see the situation from different angles and avoid getting stuck in one way of thinking.
Collaboration is so key in nursing. Okay, so we're slowing down,
Yeah.
considering all the options and collaborating with our colleagues. What else can we add to our clinical reasoning toolbox?
Let's talk about a concept that might not be as flashy as diagnosing some rare disease, but it's equally important: health maintenance.
Health maintenance. Makes me think of like vaccines and screenings and things like that. How does that fit into all of this?
It's all about being proactive with patient care. By thinking about health maintenance during every patient encounter, we can actually help people stay healthy and prevent problems down the road.
Okay.
This includes everything from counseling patients about healthy lifestyle choices to addressing those social factors that might be affecting their well-being.
So it's not just treating the immediate problem, but also looking at the whole patient and their long-term health goals.
Exactly. It can be as simple as making health maintenance a regular part of your care plans.
Okay.
This way, you have that built-in reminder to address things like immunizations, screenings, lifestyle changes, and any preventive measures that are relevant to the patient's age, sex, and risk factors.
I like that, having that reminder in place, because it is easy to get so focused on the acute issue in front of you and forget those big picture things.
Absolutely. Speaking of putting all this into practice, let's walk through a hypothetical case and see how clinical reasoning actually unfolds. Okay, picture this. You're taking care of a 54-year-old woman, let's call her MN, who comes to the clinic complaining of headaches.
Okay.
She describes them as throbbing, lasting anywhere from a few hours to even 3 days, and they're severe enough that they interfere with her daily activities.
Oof, that's tough.
She also mentions experiencing nausea and vomiting with these headaches.
Okay, so right away we have a patient with a symptom that's really impacting her life. So what's the first step?
Well, just like we discussed, it starts with gathering information.
Wow.
We learn that MN has a history of migraines since she was a kid, and these headaches are similar to her usual migraine attacks, but they seem to be getting worse lately.
Okay.
She mentions that stress often triggers her headaches, and she's been under a lot of stress lately.
Makes sense.
She's also been drinking more coffee than usual to try and deal with the stress and fatigue.
So we're starting to see some patterns here. A history of migraines, stress as a trigger, and increased caffeine intake. What's next?
Now it's time to get more objective data through the physical exam.
Okay.
You check MN's vital signs and her blood pressure is elevated, but her cardiovascular and neurological exams are normal.
Okay.
No fever, no stiff neck, no focal neurological deficits.
So one abnormal finding, that elevated blood pressure, but nothing else that would suggest a really serious or acute problem.
Exactly. Now, it's time to synthesize all of this into a problem representation.
Okay.
You might phrase it something like this. MN is a 54-year-old female with a history of migraine since childhood, presenting with chronic, intermittent, and progressive pulsatile headaches that are similar to prior attacks and appear to be worsened by current life stressors. The headaches are accompanied by nausea and vomiting. Examination reveals elevated blood pressure, but an otherwise normal cardiovascular exam and non-focal neurological exam.
Wow, that problem representation really sums up her situation and highlights all the key details.
It does.
So how do we go from that summary to figuring out the cause of these headaches?
Well, based on everything we know, the most likely diagnosis is a migraine headache. Her history, what her headaches feel like, and the lack of any really concerning findings on the exam all point to migraine.
But we can't just assume it's a migraine, right?
You're absolutely right. We have to think about other possibilities, too.
Okay.
Things like tension headaches, medication overuse headaches, or even more serious conditions like meningitis, subarachnoid hemorrhage, or a brain tumor.
Oh, wow, yeah. So how do we narrow down all those possibilities and decide if we need to investigate further?
We can use what we've learned to prioritize our thinking.
Okay.
For example, MN's headaches have been coming back for months, which makes those acute and serious conditions less likely. The normal neurological exam is also reassuring.
Right, so we're using our knowledge and clinical judgment to assess how urgent the situation is. What about additional testing? What role does that play?
Well, depending on the clinical picture, we might order some tests to rule out certain conditions or confirm our suspicions. In MN's case, given her age and that elevated blood pressure, we might consider some basic labs to assess her overall health and look for any underlying conditions that could be contributing to her headaches.
So we're using labs to help fill in any gaps in our understanding.
Exactly. If we were more concerned about a serious neurological condition, we might consider imaging studies like an MRI or CT scan.
Okay.
But with what we know so far, that's probably not necessary for MN.
So this is a perfect example of how clinical reasoning guides our decisions about testing and helps us avoid doing unnecessary interventions.
It is.
So let's say we're confident it's migraines. What are our next steps?
First, we recommend lifestyle modifications to help lessen her symptoms. Since stress and caffeine seem to be triggers, we'd advise her to try stress reduction techniques like exercise, yoga, or meditation, and to cut back on the coffee.
So we're tackling those modifiable risk factors head on.
Exactly. We can also recommend over-the-counter pain relievers like ibuprofen or acetaminophen to manage the pain during an episode. And we'd also teach her about recognizing migraine triggers and how to cope with them.
What if those things aren't enough to help her feel better?
Well, if those initial measures don't provide enough relief, we can then think about prescribing migraine-specific medications like triptans or anti-nausea meds. And for patients with really frequent or severe migraines, preventive medications might be an option to help reduce how often they happen and how intense they are.
So we've got a range of tools we can use, from simple lifestyle changes to prescription medications.
That's right. The important thing is to work together with the patient, considering their preferences and their individual needs, to find the approach that works best for them.
Now, thinking back to health maintenance, what would that look like for MN?
Given MN's age and risk factors, we'd want to make sure she's up to date on recommended cancer screenings, like mammograms and colonoscopies.
Right.
Because her blood pressure is elevated, we might recommend a lipid panel to assess her cardiovascular risk, too.
So we're not just treating her headaches, we're looking at her overall health and thinking about prevention and early intervention.
Exactly. We'd also talk to MN about the importance of living a healthy lifestyle, regular exercise, a balanced diet, and quitting smoking, especially since she has a history of smoking.
It really highlights that holistic approach, considering all the factors that contribute to a person's health.
Right. And since MN mentioned feeling stressed and overwhelmed, we might also ask about her mental health and see if she could benefit from a referral to a therapist or counselor for support.
So we're considering her mental health needs too. It all ties together.
It does. Now, let's shift gears a bit and talk about MN's elevated blood pressure. We need to figure out if this is a true case of hypertension or just a one-time high reading.
How do we do that?
We'd want to get several blood pressure readings over time to see if there's a pattern. Since this is the first time we've seen it elevated, we'd probably start by recommending lifestyle modifications, like cutting back on sodium, increasing physical activity, and maintaining a healthy weight.
So a stepwise approach, starting conservatively before jumping to medications.
Exactly. We'd also look at her current medications to see if any of those could be playing a role in her elevated blood pressure.
So we're considering potential drug interactions or side effects.
Right. And if lifestyle changes aren't enough to bring her blood pressure down, then we'd think about starting her on medication to help manage it. When choosing a medication, we'd take into account her individual characteristics, like her age, her race, other health conditions, and potential side effects.
Yes, not a one-size-fits-all situation. We're really tailoring the treatment plan to her specific needs.
You got it. Now, MN also mentioned having some urinary incontinence, specifically leaking urine when she coughs or laughs. We need to address that too.
Yeah, incontinence can really impact someone's life. How do we approach that from a clinical reasoning standpoint?
Well, the fact that she leaks when she coughs or laughs suggests stress incontinence, which is when there's increased pressure on the bladder.
Got it.
To confirm that, we do a pelvic exam to assess her pelvic floor muscles and check for any signs of pelvic organ prolapse, which can sometimes contribute to stress incontinence.
So again, gathering more information through a physical exam.
Right. And if we suspect pelvic organ prolapse, we might refer her to a urogynecologist for more specialized evaluation and treatment.
Bringing in the experts when needed.
Yes, exactly. The first-line treatment for stress incontinence is usually pelvic floor muscle exercises. You might know them as Kegels.
Right.
These exercises can help strengthen those muscles that support the bladder and urethra, which can really improve bladder control.
So giving her the tools to actively manage her symptoms.
That's the goal. If Kegels aren't enough, there are other options like medications, devices, or even surgery in some cases.
So a whole range of approaches depending on how severe her symptoms are and her individual needs.
Absolutely. And it's important to remember that MN is also dealing with some major psychosocial stressors like family issues and financial strain.
Right. We can't just focus on the physical symptoms. We have to consider the whole person.
Exactly. These stressors could be contributing to her headaches, her elevated blood pressure, and even her urinary incontinence. To provide truly holistic care, we have to address these social determinants of health, too.
So how do we bring those psychosocial factors into the care plan?
We might refer her to a social worker or counselor who can help her navigate those challenges and connect her with resources to provide support.
So going beyond just meds and procedures and looking at those support systems that can really make a difference.
Exactly. MN's case is a great example of how clinical reasoning is an ongoing process.
It is.
It's all about gathering information, analyzing data, forming hypotheses, and then constantly adapting our approach based on the patient's individual needs and how they respond to treatment.
This walkthrough has been so helpful. Thank you for showing us how all these clinical reasoning concepts come together in real life.
You're very welcome. It's been great discussing this with you.
Are we ready for part 3?
Let's do it.
Welcome back to our deep dive, everyone. We've talked a lot about the thinking process behind clinical reasoning, the steps, how to avoid mistakes. But how does all this translate to actually becoming a skilled clinician?
Yeah.
Like, what role does experience play in developing that intuition?
Experience is huge, really.
Yeah.
It lets you see those subtle things that textbooks just can't teach you. It helps you build up that mental library of what we call illness scripts.
Right.
A student might see chest pain and think, oh, could this be a heart attack? But a seasoned cardiac nurse, they've seen it all.
Yeah.
They consider so many more possibilities based on the patient's age, history, even the specific type of pain they're describing.
Right. So it's not just knowing the facts from a book.
No.
It's that deep understanding that you get from seeing tons of patients over time.
Exactly. The more you see, the better you get at spotting those patterns, those variations that make all the difference in giving good care.
Right.
Experience also teaches you to ask the right questions.
Oh, for sure.
To really listen to your patient's story and figure out how to approach each person as an individual.
It's like honing those observation skills
Yeah.
to pick up on the little clues that might not be in any textbook, but tell you so much.
Exactly. And that's why mentorship is so important for nurses.
Oh, absolutely.
Learning from those experienced folks, seeing how they handle tough situations, it really speeds up your own growth as a nurse.
Definitely. Okay, so we've covered a ton in this deep dive. If you had to give one piece of advice to nurses who are just starting out, what would it be?
Never stop being curious.
I love that.
Never stop asking questions, challenging what you think you know, and always be looking for new knowledge. Healthcare changes constantly.
It really does.
So that curiosity, that drive to learn and keep growing, that's what makes a truly great nurse.
Curiosity is key.
And remember, it's okay to get things being sometimes. We all make mistakes. What matters is that we learn from those experiences and use them to get better. Nobody has all the answers.
Right.
And honestly, that's part of what makes this job so challenging and rewarding.
Yeah, embracing those mistakes is chances to learn great advice.
And, thinking about it, clinical reasoning isn't just a skill.
Yeah.
It's more like an art. The art of listening, observing, connecting the dots, and then using that to make informed decisions that really affect people's lives.
Okay.
And that's something we can all keep getting better at throughout our entire careers.
Beautifully said. It reminds me that nursing really is a mix of science and art.
It is.
The science of the knowledge and skills and the art of compassion, empathy, and really connecting with people.
Exactly. By really embracing that art of clinical reasoning, we can make a difference in our patients' lives.
Absolutely. Thank you so much for joining us on this deep dive into the world of clinical reasoning. We hope you found it helpful and maybe even inspiring. Keep learning, keep growing, and never lose that curiosity. Until next time, everyone.